Hi guys. I hope it's right now live. I'm just opening the YouTube one so that I can also have a parallel idea of the chat that is going on from YouTube since it's a live session. So there will be a small lag between what I'm talking and the response. So yeah. Hi guys. Excellent. Right now live. I'm just opening the YouTube one so that I can also have a parallel idea of beautiful. So I have muted my phone to just see what the charts are coming so that it's easier for me to understand what's happening. So guys, am I audible? So I totally see right now a few of them joining the YouTube live session. So I'll just wait for, let's say, next 10 to 20 seconds to before diving into the questions and the discussion format. Now, in this session, I would want you guys to be very active on the chat box. There'll be a small lag. However, it will be answered. Okay. So I'll be just waiting. If you guys are able to hear me and reciprocate to what I'm trying to tell, please tell one hi on the YouTube session. Yeah. Yes, thank you, Dr. Asitosh. I've got a response from you. So fine. So I think most of you are there, or if few of you like already have got quite some messages telling that a few of you are doing duties and will be free little later. Some of you, I can really understand. That's why it's in YouTube where you would be able to again see to it later. Now I have just jotted down all the questions that was discussed in one of my personal group along with a lot of your students. So the questions are very, kind of very raw. We'll try to refine it. And second, try to get a probable answer from the existing data that we have. Okay. So let me just go to first question. Now, one of the question that was discussed was about triple hormone receptor agonist in obesity. So this is the first question. So let me see the chat box parallelly what's happening. So here retatrutide is the answer because it's if you just go through there's a triple hormone receptor for obesity which was recently had a very good study from NEJM. Yeah, the NEJM study with retatrutide, which is actually an insulotropic polypeptide and kind of it has an agonist activity to GIP GLP-1, that is glucagon-like peptide 1, and glucagon receptors. Glucagon receptors. Okay, so this will be the answer. So the aim of this question is trying to get the other options also. If you guys are able to and tell the other options, then I can right away add it to this question. So the answer for this question is retatrutide. Excuse for my voice change. I really have a a light upper respiratory tract infection. Yeah. So let me just wait to get other options. Ultimately, the right answer is what matters. The answer is retatrutide. So let me see if there are any chat box responses for the other options for this question? There'll be a small lag, but I think that's okay at this point of time. This is the first question that is being discussed today. Triple hormone agonist in obesity, a recent one, retired, right? Yeah. So we've got the right options. In case other options we don't know, which are wrong, but of course it doesn't matter. But then you guys can put up in the chat box so we can add on to the next this thing. So this is question number 2. So question number 2, not an immune checkpoint inhibitor. So any answers? Let's see. Option A, PD. Option B, CDK1. Option C, CTLA4. D, PDL1. So the previous question, some of the charts are coming now. I'll add them. Semaglutide and tirzepatide will be added to the question later. Yeah. For this question, what is the answer? Semaglutide. Okay. So here the answer is best is B, CDK1. All of you would have got it right. Yes, as per the report, most of them. But then this is how they are classified as. Okay. The immune checkpoint inhibitors, overall, the types are anti-CTLA4 monoclonal antibodies. Again, examples you have ipilimumab and tremelimumab. Anti-PD-1 monoclonal antibodies, like examples, pembrolizumab and nivolumab. Nivolumab we use in HCC. And anti-PD-L1 monoclonal antibodies like atezolizumab, durvalumab, again, use a few of them used in HCC, and a combination of these which are used. So the best answer for this question is B, which is CDK1. Okay, so now you should know what are the classifications of immune checkpoint. There are grossly 3 types and a combination of them. So this is again a very good question that's been asked. Okay, many of you have got this right. Let's go to question number 3. Now, question number 3, biofeedback example for A, fecal incontinence, B, achalasia, C, Hirschsprung's disease. Probably, I feel the question meant what is biofeedback really useful for? Now, biofeedback is really useful for anorectal dyssynergia related constipation and to some extent fecal incontinence. From the options available, I can decipher that probably fecal incontinence is the right answer. But then I am eagerly waiting in the chat box for some discussion about what the probable other options were and what was the clear question was. Of late, biofeedback is a technology where patient is given his physiological maladaptation to a particular stimulus, say whether it is with respect to defecation, he is given an idea about how he is defecating, whether there is dyssynergy, and try to get it towards normalcy. Okay, so let me see. Okay. Hirschsprung's disease is okay. It is useful in Hirschsprung's disease post-surgery when there is some form of incontinence, biofeedback is done. But then primarily as Hirschsprung's disease, biofeedback is among this useful for, I would say it is fecal incontinence from the option that is being given. Okay. Hirschsprung's disease post-surgery when they have fecal incontinence, that time it is useful. Okay. So yeah, let's see. Is there any other options? Okay, so the question now comes as a consultant described a method of biofeedback to a resident for which condition he was talking about. Okay, probably from the options, it is for fecal incontinence. If the option did have anorectal dyssynergia related constipation, then that would have been the better indication for biofeedback therapy. Okay, so now we know the scenario. It is a consultant describing a method of biofeedback to a resident for which condition he was talking about. Okay, so fecal incontinence would be the best answer. Let's go to the next question. Again, a very expected question. Crohn's disease activity index. What are all its part except? Is it a HCT, general well-being, blood bleeding per rectum? I'm not sure about the other option. Let's see what are the different aspects of this. You have component called about the stools, about the pain, about the general well-being. And then there are some points on constipation, whether there was any use of drugs, abdominal mass, and whether there was any deviation of hematocrit and deviation from standard weight. Okay, so if you see this particular option, you know that hematocrit is in itself a particular option. So you would probably, even if you respect to weight, you have deviation from weight also being a part of this particular thing. So weight gain, if at all was an option, then that will be there, because you probably are not going to expect a weight gain. So few of you are telling weight gain was an option. If that's the option, okay, fine, great. Weight gain was the option. Okay, hematocrit is a part of it. General well-being is still a part of it. And bleed per rectum. Now, bleed per rectum, if you ask me, for CDAI, even that is not a part of it. You never come across uh, the blood in stools. See, you have liquid stools, soft stools, and there are no other points about this. However, with respect to complication, again, you don't have anything which is suggestive of uh, an investigation, which means this. If it was weight, remember in the option, standard deviation from weight is given a point. So it can be weight loss or weight gain. Got it? So it will be still given a point. It is just deviation from standard weight. So here it's a tricky question. If you knew the options clearly, weight gain is probable answer. But if you knew the specifications of CDAI, they don't mention it as weight loss or weight gain. It is the percentage change or the deviation from a standard weight. So if that sits in place, then bleed per rectum will be the right answer for this question. Okay. So guys, so in this question, I would say blood per rectum would be the answer, because weight, change of weight is still an component of CDAI. Hope I'm clear. This is just my thought process. We can still discuss them again in our WhatsApp group, like what exactly the question was. Few of you are mentioning it as it was not weight, it was just body weight. Okay, body weight is in itself a component of CDAI. Next question is short stature plus obesity. This question was already discussed in one of the shots that we had discussed, and also in QRP and even Schlesinger-based tables discussion. Short stature plus obesity, it's we are still not very clear about the question. If you guys are clear about the question, do let us know. Carpenter syndrome, Prader-Willi syndrome, Alstom syndrome, and Lawrence-Moon Beetle. If you tell short stature plus obesity, many options in this are right. So what's really important for me to discuss here is an important table, which is in page number 94 of Schlesinger. This is the exact same table from my book, which I discussed when it comes to this particular genetic syndromes with obesity. One is Albright's, where again, short stature is a part. Alstrom syndrome is where you have childhood obesity, but uh, you would probably not get short stature. Lawrence Moon Beetle or Moon Bardet Beetle syndrome, again, you do have some form of short stature. Carpenter syndrome, you have again obesity, and these are all the other features. And Prader-Willi syndrome, again, obesity, failure to thrive is all part of it, and small hands and feet are all there. So, can I just get the question more in detail, please? Yeah, thank you, Dr. Dawal. Yes, this question was there in QRP. We had discussed it detailedly. Yeah, Dawal, for the previous question, the answer is bloody stools. It is not bloody stools is more a distal issue. It is not a part of Crohn's disease. If you have an ulcerative disease, then probably bloody stool should be an answer. Weight is part of CDAI. Okay, so let's go for yeah. For this, I need more modification of the question, sir. It was asked as syndrome where obesity and short stature was seen. Obesity and short stature. Okay, both of it was seen. Let's see the options again. Ideally, you even in see this, you just read about Alstrom syndrome. You have childhood obesity, okay, but there's no mention of short stature. Was there any mention of Albright syndrome in the option? We need to discuss a little more of this question. So if you see Prader-Willi, there is failure to thrive. So secondary to failure to thrive, probably obviously there will be short stature. So this question, was it kind of all except question? That's also one of something which we need to see. Because of the lag, I am really unable to. AHO was not there. So Albright's was definitely not there. So this is out. If you ask me, most of the options here will be a right answer because short stature may be found in most of them. So this is one question I think we'll probably have to go in depth. Did they mention anything about normal extremities, something like that in the question? That is something which we should look into. Many of these questions, if there is hypogonadism, that itself is going to lead to short stature. Okay. So I would say that this question we'll probably have to discuss more in depth. So we will leave it at last. See, one of you are also asking most common was asked. So most common among this, I would say what we see most common is probably Prader-Willi. Okay. So most common is the question that is asked. Okay. Most common. That we'll have to again look into it. What your most common was there in the question. Okay. Most common short stature plus obesity. See, short stature and obesity is seen in most of the syndromes. So probably the question would have been in among these, what is most common? Okay. So we'll look into it. Carpenters, again, there is obesity, syndactyly, heart disease, mental retardation, hypogonadism. So we'll wait. Okay. Yeah. So the next option is, okay, if Dr. Ashish, you have an up-to-date reference, which is great. From the reference that I have, that is a standard book, we are still without an answer. If you have that reference, please put it in our WhatsApp group. Maybe right away when we are doing this, we can discuss because there's no other way we would be able to see and match the answer from up to date at this point of time. Okay, immediately put it in up to in our WhatsApp group so that we'll be able to see whether the answer is perfect. Because here the aim is to get the questions right rather than the best answer if possible. So if you see, as per the question, it is most common, and we will take a source from up to date also and see what's the best answer. As per up to date, one of the student cells, Carpenter syndrome is the answer. Okay, we'll look into it. We'll get back to this. Yeah. So next question is, of course, it's a dual agonist, semaglutide, tirzepatide, and similar question has been asked. What I would say is, uh, There are a lot of types that you would have to know. But however, dual agonists, the few examples are tirzepatide is again in phase 3. So if the option was tirzepatide, then probably that would be the best answer for this question. However, individually GLP-1 receptor agonists, please know their names. One of them is liraglutide and exenatide. Okay. So one of Dr. Krishna Sai, the question was not short stature at all for the previous question. So guys, if you don't give the exact question, it would be difficult. So we'll mark it as a tough question to again get back and discuss. So the second question I have got is discussion about GLP and GIP dual agonist. The answer will be tirzepatide. Okay, no doubt about that. It is tirzepatide. Oh, according to Krishna Sai, it is small hands, feet plus obesity. So, small hands and feet with obesity. Then we will have direct answer for this. Small hands and feet. See, I've already marked in this. Then the answer will be Prader-Willi syndrome. Okay. Small hands and feet. Small hands and feet. Answer is Prader-Willi. Okay. Let me go back. In this question, if the answer question had actually small hands and feet, it would be, sorry, the answer would be Prader-Willi syndrome. Okay. So the next question, I think you guys have no doubt with respect to answer for the previous question. Next question is false about hepatic encephalopathy. Muscle helps in ammonia clearance is true. Renal primary source of ammonia synthesis is false because it's from intestine. Third is minimal hepatic encephalopathy is seen in 80% of patients. May be true. We are not sure. Whenever it's numbers, no, we are not sure. Total surface area of collaterals more than 83 meters square leads to encephalopathy may be true. Again, we don't know numbers. As far as we already got a negative answer, please go for this. Because remember, the synthesis of ammonia primarily occurs in the gut, in the epithelial cells. They go all the way to different parts, especially the liver and other body parts like muscles, and gets cleared. Okay, for clearance, okay, maybe this picture probably might help you. So take a screenshot of this paper and read them, especially ammonia metabolism. Okay, urea cycle and glutamine synthetase are the two pathways where they get burnt. Let's see. Yeah, this is going to tell you it is the intestinal overproduction that leads to hyperammonemia. It is not renal issue which is causing the problem. And then they get used up by urea cycle and glutathinate synthetase, and then it goes on. So the answer is B. It read about metabolism of ammonia, where it is generated, and urea, where it is excreted, how it is formed. Now, this is what we have to know in with respect to uh, ammonia and encephalopathy. Now, yeah, there were some options which were given. As a student, we are not expected to know them. But then, with respect to studies, there's a study telling total area of spontaneous portosystemic shunts independently predicts hepatic encephalopathy and mortality in liver cirrhosis. In this study, if you look at the conclusion, you have this total surface area more than 83 square as a risk for hepatic encephalopathy and mortality. So whenever it comes to numbers, okay, it's better to switch off and see if you're getting the answers in the other options. Okay, that's the way I would go about it until and unless you starkingly know about it. Okay, about minimal encephalopathy, it is so common that the studies are very less. It might be slightly less. It might not be 80%. It might have been, actually, it might be 60%. But then when you have an option which is so grossly telling that the major problem is it is produced in the kidneys, then obviously that's the wrong answer, right? So when it comes to numbers, I would approach it like this. If it is too gross that you know it, then you go for it. Otherwise, see if you have an option among others. Okay. So one of you guys won the PDF of this after the discussion. Happily, we would give that to you. Next question is Wilson's disease. Urinary copper excretion is increased. B is decreased ceruloplasmin formation. C is increased intestinal absorption. I just need to know what is true about Wilson's disease. Okay. I would want to know other options. If you guys are able to parallelly send it in the chat box, please let us know. Okay. Now, for Wilson's disease, all I would want to know is what really is happening. In case of ceruloplasmin becomes lower than normal. Serum copper tends to slightly become more. Okay, serum copper tends to slightly become more. Okay, but serum copper is not something which we really do. Next, urinary copper excretion is going to skyrocket. So it is going to increase. And copper is also increasing in the dry weight copper estimation. Okay. So this much you guys know that copper will increase in the liver, copper is increasing in the urine, copper may to some extent increase in the serum, overall copper, but the ceruloplasmin comes down. With this, if you are able to answer, liver excretion is increased was the fourth option. Liver excretion of what? Liver excretion is increased was the fourth option. D. Liver excretion is increased. Biliary excretion of copper, to be more specific, biliary excretion. Okay. Fine. So if these were all the options, we'll have to look at the natural history of Wilson's disease, where how much copper is taken in, how much gets absorbed, how much gets in the liver, how much goes to the biliary circulation, how much is in plasma, and how much is renally excreted through urine. Okay. So I would say that probably if these options are right, we'll get back to answers a little later. Okay. And I hope that what they're asking is about which among the following is actually true. Now, from the current option, most of it looks like it is true. So we will have to probably little fine tune this question. Let me see if there's any fine tuning. But the good thing is with this question, we know that biliary excretion is increased is one among the options. Okay. So we look at it at this point of time. Okay, it's a true question. What is true about liver? So with this, I think the natural history of liver disease, if you see how much grams of copper gets in different places, especially in Wilson's, will give you a better answer for this particular question. Okay. So if you see, urinary copper is definitely increased. Right away, if you don't know anything, that is the only true in this particular option. Okay. Some small things may be very different from others. If I was there, I would have marked A as the answer because obviously liver copper, the copper in urine is high. Next. Not a first line of drug for malignant HCC. So off late, there is some changes in the first line of drugs for HCC. We all know that there are some first lines, and atezolizumab and bevacizumab are also part of the first line along with durvalumab and others. So let me just show you a brief picture of the recent HCC drugs approved by EM and FDA approval. So if you see the first line, you have durvalumab and tremelimumab, at acetolizumab and bevacizumab. lenvatinib, and sorafenib. So these four, if was there in the option, don't mark them. Anything else, that is ramucirumab or regorafenib, if are there, then that will be the answer for this question. Hope this particular picture gives you a better idea of what is first line, what is second line, and what is third line. Okay. Uh, Now there's no discussion or any charts that I'm able to see right now. So I'll give you 20 seconds for the lag period so as to catch up with this, and then I'll go to the next question right away. Okay, let's slowly go to the next question. A TB workup is least required before giving. This may not be a gastro question, but then I have just added it here. So this is a good monitoring novel therapies chart for rheumatoid arthritis. And you see this, if you see it, anakinra, it's so beautiful, right? You don't have to do anything with it. You don't have to do C for TB or anything. So you just go through this particular key monitoring frequency. TB means that you'll have to look for signs and symptoms of TB and have to evaluate it. Abatacept is the next best option. Most of the options will be needing a monitoring for TB. Okay, so that's about it. Let's go to the next question. With respect to cirrhosis and malignant portal vein thrombosis, what is false? I hope this question is right. Not given if planned for liver transplant. Now, what do you mean by not given? Are you talking about anticoagulation? Which I'm not sure. Anticoagulation. Okay. Second, query, improve at cost of bleeding from other sites. I'm again not sure what the option means. Third is improves long-term survival. I think what we're talking about is anticoagulation. The anticoagulation not required for malignant portal vein thrombosis. So, okay, so let me just be more clear with respect to this. Abrar Hussain has asked the answer for the previous question. The answer for the previous question is Anakinra if it was there. The next best answer will be Abatacept if it is there. Okay, so the best answer will be Anakinra. Was it there in the option? Yeah, it is there. So B is the answer. Okay, just for Abrar's sake, I'm going back. Yeah. Okay. So here, with respect to anticoagulation, okay. Now, in the question, was malignant a part of the question? Because many things change if it was malignant. Okay. If this is question there, then we'll discuss it in more detail. These were my questions. And second option is not at all clear. Query, improve at cost of bleeding from other side. So does it mean that you are going to give anticoagulation that is going to increase the bleeding chances elsewhere? Then it is true. We are always giving anticoagulation with the rest. So I thought, let's at least know the concept. Whenever there is a cirrhosis with portal vein thrombosis, now if there is chronic, okay, without any portal vein remnant or any splenic vein axis, there's no need of any anticoagulation. If there is more than 50% occlusion or a progressive portal vein thrombosis, okay, of the trunk and both main branches of a potential transplant candidate or extension of thrombus into SMV. So either up or down if it extends, you have to consider anticoagulation. Only problem is if there is history of recent bleed or a hard to treat ascites, probably don't think of anticoagulation. Think of directly tips or mechanical thrombolysis. Okay. Otherwise, you can always do anticoagulation, reassess after 3 to 6 months. If there is partial recanalization or resolution of occlusion or stabilization, you can continue anticoagulation till life or till transplant. If the patient has progression of PVT or lack of improvement with anticoagulation is when you start considering for tips or plus or minus mechanical thrombolysis. And this much concept I can tell you. But if the question clearly mentions malignant portal vein thrombosis, the treatment is entirely different. It is probably not even anticoagulation. You will look at options like TARE, radiotherapy, SBRT, etc. Okay. So one of you, Dr. Shabnam, has told malignant was not in a part of option. Then you have better things to think about it. So one of you is like it was malignant. So Dr. Shubham Jain says malignant was not there. Dr. Abrar is telling uh, for it. So for me, it gets very difficult. What I can grossly tell you is if there's a malignant obstruction, our thought process is very different. If it is just portal vein thrombosis, our options are very different. Okay. So this is again a contentious question. If malignant was surely there, then why would you give anticoagulation? Isn't it? So don't you think about it? You start thinking with respect to others. So let's think that anticoagulation was there. Now, if malignant portal vein thrombosis is there, you're not even going to think about liver transplant, minded. Second, improve of cost of bleeding at other sites. Yes, if at all you're going to give anticoagulation, again, it is going to increase. It improves long-term survival for a malignant block, or probably not. And the anticoagulation is not required for portal vein thrombosis is probably right, because for malignant portal vein thrombosis, you don't anticoagulate. The treatment is very different because it is not a thrombus. So you have to differentiate between bland thrombus and malignant thrombus. I hope you guys are clear. So if the options are like this, with the malignant, what is false, then I would say you would not even probably consider transplant as an option. Okay. And many options are likely to be false. False, I feel many options in this particular question can become false. Okay. So I don't have an answer for this question at this point of time till we have better options. Then there was this question about periportal fibrosis, Pash stain with a HPE image diagnosis. Options were alpha-1 antitrypsin, cystic fibrosis, Wilson's disease, and Dubin-Johnson's. What I want you guys to tell me is, what were the picture like? Was it like cytoplasmic inclusions were seen or not? Then we can tell you what probably was seen. This is completely a question which can only be answered by somebody who has seen this histopathology picture. If one of you get it in the internet and you feel this is how it looked, please put up in the WhatsApp group so that it's much easier for us to discuss this particular question. Okay. Yeah. So the next question is true about Gilbert. Somewhere in some table, I'm very happy that this part was discussed, that it is protective in ischemic heart disease, probably because of the increased unconjugated bile, which will be useful as an antioxidant. Now, this we all know. Sometimes we even, when a patient comes to our OPD, telling, sir, this is jaundice. I have this from a long time. I'm really worried about it. Incidental LFT derangement. Most of them tell them that you are lucky that you have this. Probably go, you are probably going to survive much beyond than most of us. So that's how I give them a positive energy. So happy that the question is here. Direct answer is protective for AVCAST because of the antioxidant effect of the increased unconjugated bilirubinemia. Okay, so I'm not getting into depth. Let's go. We have an answer here. So here we have a question. So according to Prabin, in the chat box, he has written that it was diastase resistance positive periportal stained globulins. If that was the answer, then alpha-1 antitrypsin deficiency would be the right answer. Okay. So yeah. So the next question here, question number 14, where a patient with chronic pancreatitis is symptom-free for some period, presented with new onset pain, you find a lot of stones in GNU, body, and a proximal stricture. Okay. What's the next best test to do? Is it US plus a biopsy? Is it MRI abdomen? Is it ERCP with pancreastomy? Or is it PET-CT? Now, I'm somehow not convinced with the terminology pancreastomy. So I probably would be more happy if you guys are giving me better options. Whenever you have a stricture and a proximal dilatation and patient has stones, if it is near the head, we would do an ERCP, go to the pancreatic duct and try to remove the stone. If it is a diffuse disease, we would probably go ahead with other options like, say, ESWL to go ahead with the procedure. Okay, this much I can give you as a concept, but then for a diffuse stone disease, ERCP may not help until and unless you have a significant stricture. Okay. So that is what I would say is the next step for diagnosis of carcinoma. See, here there is no question of carcinoma here. Pain and stricture. Probably the stricture is because of chronic pancreatitis, which is calling upstream dilatation and stones. Probably by removing the stones or the stricture dilatation, you might help. So ERCP probably will be the best option in this particular question. But if the stone burden is too much, then this. Only thing is, if the question also had there was a mass at the head of pancreas or something like that, then US with F&B would be a better option. There is no mass in the question. What are you going to go? If at all you do any US and you get a mass, then you take it out. Okay. Therapeutically, because there's new onset pain, you have to probably treat the stricture. Okay. If suppose malignancy was mentioned in the question, the answer goes to EUS and FNB. Okay. So I would say if malignancy was mentioned in the question, as per few of you in the group, then this would be the best answer. If no malignancy, you want to just therapeutically treat the patient, then C would be the probable best answer. They will give you clues. Patient recently developed pain, loss of weight, steatorrhea, new onset diabetes. They all are giving you clues that probably you're dealing with the mass lesion. Then EUSFNB. Okay. Yeah. Mass suspecting malignancy, as per few of you, Dr. Dawal has surely mentioned there's a mass in the question. Then the best answer is A. Okay. Yeah, no doubt about that. Excellent. This is the next question. Acute right upper abdomen pain. There is bulky pancreas, mild IHBR, CBD is 12 mm, which is quite significantly big. Next best step for management. Acute pain, dilated CBD. What will you think of? A, EUS, B, MRCP, C, ERCP, and D, CT. I hope this question is right. If this question is right, then we are probably dealing with the right options. The right options, if you have a acute pain, dilated CBD with a bulky pancreas, you would want to see the different structures, especially the CBD and the pancreatic duct. What is its nature? A non-invasive test would be better. It would be MRCP. The question a little more like jaundice, that. Probably based on the chances that you're dealing with the choledocholithiasis. Again, MRCP versus EUS will become an option. Right away, I don't feel ERCP cannot be an option at this point of time because we still don't have a diagnosis. CT scan again may help us to find out what we are dealing with. But from the options that are available to get a blueprint, I would probably do a CT scan first, and then we'll get a further idea on what to do. So, because both PD and CBD, both of them are involved in this particular question, we have to see both these organs carefully. Non-invasively, MRCP will be mentioned, is better. If not, you might have to do an EUS followed by ERCP in the same sitting. Okay. So, as per few of the students, no stone was visible on ultrasound was mostly given, sir. Great. They mentioned recently ultrasound or something was normal with a dilated CBD. Just dilated CBD and PD bulky, probably very non-specific. Probably MRCP may be a better choice. Okay. Yeah. We'll get back to this question. Please give us more data. MRCP may be a better question. Severe pain, patient cannot get into MRCP, can't get an MRI done, then you might have to probably get a CT scan. Okay. Just ultrasound was not diagnostic. Next is Advantage of EUS guided liver biopsy over percutaneous. A, reduce pain. B, more sample yield. 3, more samples for portal tract. D, only right lobe can be biopsied. No, when you go via an EUS, this is liver. We can take biopsy from left lobe. We can take biopsies from right lobe when we go from inside. Pain may be reduced because we are doing it under anesthesia. Percutaneously, when they do capsule of the liver is struck, so pain may be there, even there, but pain will be there here also. But then because you're doing it under sedation, it might be negated. But here also you're going across the capsule. More sample yield is still questionable because percutaneously you may get more samples. So I would say at this point of time, reduced pain may be slightly better option and an answer. So there is a table comparing different options, indications, advantages and disadvantages versus percutaneous and endoscopic ultrasound guided. What we can know is percutaneous wise increased sampling variability, less tolerable, require more passes, increased risk of complication. These are all the problems with percutaneous. The complication still is there is pain. But if you see, abdomen pain can even occur here. So we can't do a head-on-head comparison here. But however, there's increased tolerability, decreased complication, and we can have a lot of good things like we can view the anatomical structures quite well on the um, US procedure. Okay, so that's about this. So let's go to the next question. Most common site for duodenal lesion is 5 centimeters below the GE junction along the lesser curvature. This is a sine qua non. We all know this. Hopefully, most of you. Oh, one of you have a doubt whether it was EUS or transjugular liver biopsy that was asked. Just be sure, guys. Suddenly, you're bringing bonkers here. So transjugular was there in the option. Then it's usually used in coagulopathy, and there is decreased risk of complication, more tolerable, useful for obese, sometimes patients with ascites and this and that. So disadvantages of transjugular liver biopsy was probably asked is as per one of the student here. Then the dynamics changes. Guys, just read this table quite well. You will have an understanding of which biopsy is better and what to do. The concept is more important. This was not an okay. So most of you are like Dr. Dawal Patel says EUS for sure. So fine. No doubt EUS is the question. So answer for this is quite straightforward. It is 5 centimeters from the G junction along the lesser curvature. So the next question is, a 60-year-old male with hematemesis with history of low back pain on diclofenac since 3 days while having a large 3 centimeter ulcer in the distal body of stomach. Which one of the following is not a likely cause for ulcer? Not a likely cause means among these NSAIDs can cause ulcers, malignancy can cause, H. pylori can cause ulcers, lymphoma may be least among these particular options. This is what I feel because a large ulcer in a stomach, probably malignancy should also be considered. Diclofenac or the NSAIDs can tip the balance and make any ulcer which is already existing also bleed. So to suddenly think about a lymphoma is little far-fetched. It can be true, but least among the given options. Yeah. So let's go to the next question. Obesity does not increase risk of which cancer? I would say it increases risk of all malignancies, but from the given option, probably lung is the best answer because according to few studies, what I could go through, obesity and relationship with malignancies, I did not find lung cancer as an important risk factor. Okay, so probably that is the best answer. From our perspective, from a gastroenterologist perspective, esophagus, hepatocellular carcinoma, pancreatic carcinoma, stomach, rectal, and colon. See, we have quite significant number of malignancies which are directly, even gallbladder cancer, are all related or have an association which is quite significant with respect to obesity. Okay, so a lot of loves from most of you guys, so I'm happy. So yeah, with this particular question, I think the lung malignancy is probably not associated with obesity, but if you guys have a reasoning for it, please tell it. I'm not, which I would not, I'm not able to give it at this point of time. Okay, so let's go for the next discussion. In HBV patient, fibroscan more than what kilopascals is suggestive that the patient has portal hypertension. Is it more than 10? Is it more than 15? Is it more than 20? Is it more than 25? What are you guys thinking about? My doubt is, initially when I saw this question, we all do fibroscan and we know that more than 15 is kind of something which we'll start thinking that F4 fibrosis and more is there. But the question here is portal hypertension. Now, fibrosis is not equal to portal hypertension. If they tell you clinically significant portal hypertension, then the answer will be different. More than 25 is what will tell you there is clinically significant portal hypertension. Between 15 to 25 is like borderline there, where you look at platelet count into question. So it was clinically significant portal hypertension, as per most of you. Okay, clinically significant means the answer would be 25. Then directly we jump to this particular discussion. Quickly take a screenshot if you can, or the PDF will be soon sent to you guys. Don't worry about it. So here they define like less than KP, what to do, less the more than 15, highly associated with the new concept terminology called as compensated advanced chronic liver disease. In fact, guys, as clinicians, we should not be calling the patient cirrhotic because cirrhotic is a histopathological diagnosis. So nowadays, the terminology is more moving towards telling chronic liver disease. Is it advanced chronic liver disease? Is it compensated advanced chronic liver disease with short form, what you call as CACLD? Okay, so what they say is there is a simple rule of 5 where you can say 10, 15, 20, 25, combined with platelet counts when we use Baveno for consensus. Forget about the gray zone 15 to 25. I would say that more than 25 is sufficient to rule in clinically significant portal hypertension. Read this line again and again. You'll have a good idea of what's happening. Okay, then look at this picture. Again, they're in the same Baveno 7 consensus. More than 25 is where we'll be thinking of clinically significant portal hypertension. So I hope most of you have got it right. Yeah, most of you have even typed Baveno consensus, this, that, 25. You've known this, like you guys are good, excellent. But then for practice, this is what we all do as bedside to the patient. We do fibroscan. Always remember CAP score is for steatosis, okay? Which is again from the same machine. Don't not get confused. Second is the cap, the LSM is F4 fibrosis. So here, F4 fibrosis, the cutoff is somewhat, you can see that approximately for different diagnosis different, but approximately you can keep it as say 15. More than 15, majority of them are thinking it is F4. But more than 25 is where we should start thinking of clinically significant portal hypertension. Okay. Best answer for the question here is 25. Okay. So one of you have a question, have an issue with question 18 being different. If you have question 18 is different, sorry, I'm just going back to it. If question 18 is different, what is the difference? Please mention that also. No. NSAIDs cannot cause malignant ulcers. NSAIDs can make an ulcer which is already there because of malignancy bleed. Understand? Suppose malignancy has grown in a person from a long time. NSAIDs can tip the balance and the patient can bleed. Got it? Because it's a friable tissue. That's what I meant. Okay. It's not like NSAIDs will cause lymphoma. NSAIDs will cause malignancy. No, the question was not like that. The question means the patient has taken NSAIDs. He has come to you. He has blood. You have a large ulcer in the stomach. What are you thinking of? Got it? Yeah. If there are most likely in the question, then NSAID related ulcer. Which among the following is not a risk factor for small intestinal carcinoma? As soon as I saw the options, what I was thinking was microscopic colitis. Why would a colitis cause small intestinal this thing? This is very, very base thinking. Okay, I didn't even think anything else. Rest options were Crohn's, affects small bowel. FAP, it, you get polyps all over the body, so it's okay. HNPCC, probably I didn't have any idea about it. But then, why I'm thinking and help you guys tell that, start thinking in a simple way, slowly add on data to it. As soon as you see the question also, and you didn't know anything, still probably you could have answered the right answer as microscopic colitis or anything which had colitis with it. Let it be collagenous colitis or whatever it is. Okay. So let's now go actually to the theory part and see. This is from page number 2061, the recent Schlesinger and adenocarcinoma of small intestine. What do they say? Celiac disease is a risk factor. We know small bowel is involved. Crohn's, again, sometimes duplication cyst and Meckel's diverticula. FAP, yes. History of cholecystectomy, which I was not aware till now, but then now I should be more careful about it. Ileal loop conduits or ileal pouches or ileal cystoplasty, where all the ileum is somewhere involved in the surgery. Juvenile polyposis syndrome, long-standing ileostomy, especially in Crohn's disease, Lynch syndrome, what you call as HNPCC, and Peutz-Jeghers syndrome. So most of this polyposis syndrome, you can get this. Ujjwal Mittal is asking me 3 days history of NSAID can cause large ulcers. Bhaiya, you become a gastroenterologist and see you can get ulcers in no time with NSAIDs. Of course, because the size is large, I would see that probably malignancy is something which you should really consider. Okay. But my only thing is in the previous question, can you just mention a little more about the ulcer? Did they tell it was ulceroproliferative, this and that? Then more clues towards malignancy is there in the question. If not, I'm telling you, NSAIDs can cause any number of big ulcers. Don't worry about the size. We have seen small bowel ulcers. We have seen quite non-specific big ulcers in the stomach also. But luckily, most of them will be clean based. The surface is not everted. There is no, doesn't look like a malignancy. Okay. So I would say it was 3 centimeter deep ulcer, surface, this, that, clean based. I would still go for NSAID related ulcers only. 3 centimeters is still not a problem. We have seen, but then lymphoma will be the answer if it is least possible. Highest possibility, I would go for NSAID related. But then if they tell you averted ulcer or proliferative, I would tip the balance towards uh, malignant ulcers. Okay. Hey, one of you are even telling 3 centimeter ulcer at duodenum. Then see anything in the duodenum. Okay. Unlikely malignancy. It is most likely related to H. pylori or it is NSA related. Okay. So Dr. Krishna Sai Paluluri, sorry if I pronounce it wrong. If few of you, also Dawal Patel feels it is duodenum. If it's stomach, thought process is think of malignancy. If it is duodenum, NSAIDs, one day, even one tablet of NSAIDs can cause the mucosal breach and ulcer in a stressful patient. So don't worry about the duration. He need not take it for months and months. Okay, remove that concept out of your head. If it's a duodenal ulcer, I will go for NSAIDs. If it's a gastric ulcer, everted margin, this and that, more suggestive of malignancy, I will go for malignancy. Okay, let's distal stomach only. Distal stomach was 100%. Okay, then why did you guys? You only see what is coming on the chat box. One of you is 100% sure it is in duodenum. One of you is 100% sure it's in the distal stomach. Majority have told you distal stomach, so I will take it as distal stomach. Distal stomach, and I said large ulcers are common. Okay. Still, I'm confused between these two options. Little more data. That particular moment, I might have gone for malignant ulcers also. But the best answer would be NSAID-related ulcers. Okay. So this question is discussed. Let's go back to this. Histology of celiac disease treated with GFT with continuing diarrhea. So patient is on GFT but still has continuous diarrhea. March 3 histopathology is still showing IEL. Means that probably the patient is still taking somewhere GFTs. Okay. He's not in GFT. He's having some food intake which has gluten. That will be the first thought process. Later, we'll start thinking whether what are the different options. But first of all, I have three different options in this question. Sorry, five options in this question. I would say that some hard duplication. So anyway, the concept is very clear here. When a celiac patient with a gluten-free diet has persistent diarrhea, what all should we think of? Now, this particular study will help us with that. There were around so many patients who experienced this and had chronic diarrhea after treatment, 17%. The causes of diarrhea in the remaining patients predominantly was microscopic colitis. Few of them had exocrine pancreatic insufficiency. Few had dietary lactose and fructose malabsorption. Few had even anal sphincter dysfunction leading to incontinence. And some were diagnosed as superheaded IBS. One did have an persistence of gliadin antibody. So in this question, I would probably tip the balance towards if they had mentioned that still he has not taken any diet, non-compliance with diet would have been a better answer because it is still March 3, IELs are still high. If that's not there, then the next option would have been probably microscopic colitis. Again, differences between lymphocytic colitis, collagen colitis, at this point of time, it is difficult to tell. Okay. So the best answer would have been celiac disease if it was there in the option because of non-compliance with GFT. The next common one would have been microscopic colitis. Okay. Classification of Barrett esophagus, we had discussed so in the QRP and many times. I'm very happy if you guys have got it. It is Prague classification. Okay. If you guys have not attended QRP, didn't know this, okay, it's fine. You would have answered other questions, right? Prague is a classification for Barrett's. This question is false about Barrett's. Now, option says columnar epithelium is replaced by squamous epithelium, entirely ulta. Okay, so this is definitely false. Answer is A. Rest of the options I'm not bothering to see because I'm sure that if at all this option is right, this is wrong for the particular question. So it will be the right answer. Okay. Dr. Rohit has a doubt. IEL more than 20. So lymphocytic collagenite, something he has mentioned, but okay. IELs being high can also be a part of celiac disease per se, right? Celiac disease, the mass classification, IELs is a part of it. So it doesn't tell you much new things. And lymphocytic colitis, of course, you can take it, but that will be my second option had the option not had celiac disease. Got it? So I'm not telling it's wrong. Microscopic colitis have two varieties, collagenous and lymphocytic. So you are right. Lymphocytic colitis is the best answer in this particular question. But if it was mentioned the same way it is, if the question had little differences here and there, then I would have marked something different. Okay, great. So thank you, Dr. Dawal. This question was there in PYQ QBank of DocTutorials. Thank you. So good, you guys have got it right. Antidote for Leflunomide. Again, a discussed question. I had even mentioned it in one of my WhatsApp group as a question some months ago. The answer for this is cholestyramine. Of course, that time we had even discussed the dosages and other things. But then if you are in the group for a long time and not known this, you would have marked it right at this point of time. You been in the group for a little longer. Uh, Antidote for leflunomide is cholestyramine. Leflunomide, there are sometimes they can give you a clinical scenario. Somebody on leflunomide trying to plan pregnancy. You can't tell them don't plan pregnancy for 2-3 years, right? Because that's the clearance time for leflunomide. Sometimes you might have to give cholestyramine and prepare the patient to get pregnant next. Okay, so these are clinical scenarios, but then here question is straightforward. Cholestyramine is something which you can use. Okay, next is um superb, superb. Again, QRPs and PYQs, it's been already there. Very good. Which parameter which is used in diagnosis of achalasia? I think this achalasia term is wrong as per most of you. It is for diagnosis of hiatus hernia, right? What you basically use here is LES and the distance between LES and diaphragmatic crux. Now, I'll make it understand a little better by showing you a picture. This is how normal manometry picture looks, where you have a single LES. And the diaphragmatic thing is so close to it that it's like a straight line without much gap between them. Whereas if it is hernia, look at the gap between LES and the diaphragmatic pinch. Okay. So it is the distance between LES and crux where you decide between what type of EGJ it is, and you have an idea about what kind of hiatus hernia you are dealing with respect to manometry, that is HRM manometry. Okay, I hope there is no doubt with this question. Again, Leon consensus, already I put up in the group to read a good Leon's version 2. At this point of time, 80 more than 6 is what you have to remember, but there are so many parameters. I think maybe in a day or two, we'll discuss that particular patient's case, which I put up in the group, where the patient had significant AT, significant reflux, significant SI, symptomatology index, and symptomatology association probability, and also mean nocturnal basal impedance was also very low. So everything being positive in a patient. Superb, right? We'll discuss each step later. But at this point of time, this question, Leon considers 80 more than 6 is what is important. But however, if the patient, if they had mentioned more data, whether it was on therapy, then the cutoff becomes more than 4%. Okay. So please let me know if the question did have any other changes. Okay. And the recent version, even the recent version says that GERD LA grade B, the Los Angeles grade B, is also considered as conclusive evidence for GERD. Initially, it was just C and D and Barrett's and stricture, but even B is included as conclusive evidence of pathological GERD. That's one more change there. Okay. Yeah, this is from Lyons. We can see here. Firstly, you see whether the patient is off therapy or on therapy. For off therapy, 80 more than 6 on a 24-hour period study is conclusive evidence for pathological reflux. And new thing that has been added is even grade B also has been added here. Suppose if it is on therapy, even 4% becomes significant. Okay. Then adjunctive and supportive evidences, you start getting newer things like MNBI and symptom association start coming into play. Okay. Excellent. Ujjwal Mittal has spot on answers. The other options were 80 less than 6, 80 more than 4, and 80 less than 4. So still they might confuse you. Just see if it is off therapy or on therapy. That is my only request. If it is off therapy, more than 6 is correct. If it is on therapy, more than 4% is also correct. Okay. We are just trying to be more smart for next year's questions. Which of this is not a class 1 indication for therapeutic apheresis as per ASFA classification? Okay, we don't know about ASFA. Let's think that. Of course, we might not know. The ALF, you do plasmapheresis as a bridge to transplant or as a destination therapy. Fulminant Wilson's disease, again, we use it. Acute and chronic liver failure, PLEX is still an evolving indication. So among this, the least is 3 at this point of time. And then sensitization of ABO incompatible living donor hepatic transplantation where apheresis is done. It's a class 1 indication. So option C is the answer. However, this is the study you guys have to go through. According to the study, if you have a big table of lot of neurological investigations and lot of other indication from hematology, which is there. What I want to tell you from a gastro and a hepatologist perspective, for liver transplant, therapeutic plasma exchange is a category 1 for living donor desensitization. You also find it for acute liver failure and fulminant liver disease also you get to see it. So the answer is acute and chronic liver failure. Yes, desensitization. Perfect. Yes, that's what I've told. Desensitization of ABO incompatibility. So maybe in the question, sorry, we'll have to mention it as desensitization. Obviously, you're not going to make it sensitized. Sensitization. Okay. So this is the question. So with the answers I've showed you from the large table, I've just cut few important things and put across what's really important for us. Next is Mallory-Denk bodies, or also called as Mallory bodies, can be visualized with which immunostain? Is it membrane epithelial antigen, desmin, or vimentin, or ubiquitin? I will give you, say, next 10 seconds. Please go through them and tell me what the answer is. Then I will tell you what is my response to this question. Because there's a small lag, so I'm missing real important discussions with such active group that's there. So really happy if you're quite happy that you guys have subscribed to the question bank and QRPs. So of course we would have discussed many of them before, but these are all, some questions are really good, you know. I was really happy with these questions. So here, the answer for this question, if you ask me directly, if you see this question, would you know, can you rule out something? Probably not. But then there are some authors we see, and sometimes textbooks are always there. What you have to know is what are the contents of Mallory-Denk bodies. Its contents is P62 as sequestome, ubiquitin, and an intermediate filament protein keratin 8 and 18. These are what it is made up of. Okay. It can be differentiated from others, but then if you have these three or any of the immunostain for these, you can detect it. From the available option, I would say that ubiquitin is the best answer because ubiquitin is a part of it. So if you stain it, it means that it maloding bodies is there. Okay, it's a simple way of to think it. But then, yeah, it's a question. If you know now, probably it gets repeated later. And second, if somebody has got it wrong, if majority of students got wrong this time, then this question will come next time. Okay, that's how they select questions, telling which is rank deciding questions. Okay, so probably this is one of the rank deciding questions, guys. This is a beautiful question about a new concept from Bavino 7. If you guys have read some of the articles on Bavino 7, then few of you might have answered. False statement regarding hepatic recompensation. Recompensation is a new phenomenon where a patient gets decompensated once and then slowly becomes normal because the trigger or the inciting factor is not there. Like say HCV regimen for HCV related chronic liver disease, or alcohol for a patient with alcoholic liver disease. This is just a small example. What they say is not described in MAFLD or NAFLD. I'm not sure. D is no decompensation in the form of ascites, bleed, or HE for a minimum of 6 months. Now, I feel minimum of 6 months is wrong because as per study, it is 12 months. Okay. Beta blockers should not be stopped even if blah, blah, blah. I'm not sure about what the option is. And fourth option is also not there. So if you guys have some options for these questions clearly, please let me know so that we can add it on. But what you really have to know is what is this Bavino 7 consensus talking about? The new recent definition is called as hepatic recompensation, or also can be simply termed as clinical improvement, where there is partial or complete regression of functions and structural changes of cirrhosis after removing underlying etiology. So how do you quantify it? That is persistent removal or suppression of primary etiology of cirrhosis associated with the resolution of ascites or overt encephalopathy with after treatment discontinuation and absence of variceal hemorrhage for more than 12 months. So 12 months is the key here. It is not 6 months. And third is sustained improvement in synthetic functions like albumin, INR, and bilirubin. So this is the criteria for clinical improvement, or what you call as hepatic recompensation. Oh, great. Some of you have got it right. You guys have told 12 months. So the option answer here is B. Okay, take a screenshot of this paper and CAM question in confusion. I'm not even sure if it's a gastro or hepat question. Maybe it is somewhat related to us also. So I've included this question. Please tell me what the options were. Right now we are out of options. Okay. Yeah, the fourth option was normal albumin IR mostly. Okay, maybe now that you know the definition, it's 12 months and not 6 months, you will know the right answer. So again, this is a tentative question for next time exam also. So hepatic recompensation is something new. Majority of the students would have got it wrong. Whoever got it right, it's a rank deciding question. So it's going to come next year, next session. So CAM questionnaire again, I'm not sure what the question is. Was it about confusion assessment scale and whether it was a component of it? The best thing I can come up with was this particular picture where it has an thing of whether the onset. Second was about methods about assessing the inattention. Third was about disorganized thinking. Again, there are various RAS scales for that also. One was a scale about anxiety and depression scale, and one was assessment of altered level of consciousness. So A was inattention, altered sensorium. It was not gastro. Okay, guys. If it was not gastro, I'm more than happy. But then, from the question perspective, know its components. Probably next time it might even come into gastro. Uh, Acute or fluctuating course. Second is inattention. Third is disorganized thinking. And fourth is altered level of consciousness. These are the four components of CAM. Okay. So great. Happy to know that this question was asked, and it is about the components, right? It is about the components of the CAM score. But next question is a patient presented with melena, upper GI bleed, NG tube showed a lot of clots, BP was normal. All are components. See, in this question, no need of question also. It's simple question where they're asking what are components of local score except age, comorbidity, hemoglobin, UGI, stigmata of bleed. I've already explained in most of my previous classes with even tricks called as A, B, C, D, E to tell you what are the parts of it. Now, let's go back to it and see what is A, age. So age is a component. What is B, beats per minute. B2 is blood pressure, that is systolic blood pressure. C is comorbidity. D is diagnosis. E is endoscopic stigmata of recent bleed. Okay, so all these are components of this particular thing. So now let's go back with this much knowledge about A, B, C, D, E. What are we seeing about in this particular question? So the best answer is, yeah, perfect, Dr. Krishna Sai. That's the ABCDE I was talking about. A is the age, B is the beats per minute one, which is heart rate. Then the next B is systolic blood pressure. C is comorbidity. D is diagnosis. E is endoscopic stigmata. So what are you thinking about? What's the right answer? Hmm? The right answer is hemoglobin. Hemoglobin is not to be seen anywhere, right? So it's an investigation which you do when the patient comes to you, and then you do an endoscopy and see its findings. So hemoglobin or the blood test, lab test is not a part of ROCAL score. So the answer is hemoglobin. I've never mentioned a H in that particular option. Okay. Now, imaging of a fatty liver. So fatty, I'm not sure what the question is, but however, from this option, I can tell it is hypointense on everything and hyperechoic on ultrasound. So A would be the best option if the question was all except. Okay. So just we have a small table about what is it. In ultrasound, it will look bright. In rest of it, it will look dull. So accordingly, in CT, it is called hypodense, and in T1 weighted image, it is called hypointense. And why each of it, I'll send this PDF across, take a screenshot, read them in your free time. Okay. Next question. Don't want to take too much time, easy questions. A 35-year-old with a family history of some carcinoma in the intestine, and the family member, it occurred at 45 years, most appropriate for surveillance for a high-risk patient is always colonoscopy. It's just about timing. So timing is, you just see, this is patient with a family history of colorectal carcinoma. What you do is colonoscopy is the best way. So that is the answer. But when do you do it? Preferably 10 years before the youngest case in the immediate family. So if the family member got the malignancy at 45, you start getting screened at the age of 35. Okay, so that will be the kind of question they would expecting. So in this question, I would say colonoscopy is the best answer. It's not FOBT. If other options are there, please tell me. If there are other options which are confusing, then we can go in depth. Next question is about refractory hepatic hydrothorax. Options are pigtail in pleura. It's one of the options. TIPS, very good option. Liver transplant, fantastic option. Alpha pump is an option for refractory ascites and not for hepatic hydrothorax. Maybe you can connect it there, but then till now, I don't think anybody has done it. So probably the best answer is still D here. And just to help you out with a small table and pros and cons about each test. For refractory hepatic hydrothorax, you have thoracocentesis, TIPS, pleural catheters, liver transplant or pleurodesis or surgical repair. Okay, these are all the ones with the respective pros and cons. You guys can go through in your free time. Okay. That's what I'm telling Dr. Chetan. Age 35, do a colonoscopy. Okay, you want to screen and you're a high-risk patient, colonoscopy is the best test. Sorry. And 35 years also, 10 years exactly before the 45th year when his relative had the malignancy. So excuse me for my cough. I have a small, probably an upper respiratory infection. So let's go to the next question. A 35-year-old lady, immediate vomiting after intake of food within 30 minutes. No dysphagia, no nausea, no retching, no weight loss, normal BMI, best treatment, APPI, prokinetics, CSTCA, and D-diaphragmatic exercise. Okay, let's see what you guys have thought about this question. I'm just waiting in this phone, looking at options. So, guys, let me know what are you guys thinking about. Effortless was there. ICD is no contraindication for hepatic hydrotherapy. ICD is not a contraindication, but generally we don't prefer it because of the increased infections, this and that. But then if it's refractory, breathlessness is happening, you have to do it, right? Effortless vomiting was there, so prokinetic. Patient is immediately vomiting. What are you thinking of? Immediately vomiting. They are not telling GERD, TCA, prokinetic. So as soon as I saw this question, what I was thinking was, I'll tell you what I was thinking, but then it's up to debate, of course, because the data from this is the question that you have told. They are never going to directly tell you what we are dealing with, right? See, the patient is a 35-year-old woman. Second, immediately after eating, she's vomiting and within 30 minutes. They're not told like immediately means 5 seconds or 2 seconds where immediately it is coming out, right? 30 seconds it is coming out. There is no retching or nausea, which is important. So we are dealing with rumination is what first I was thinking. So when we are dealing with rumination, directly the answer goes to behavioral therapy, CBT, and diaphragmatic exercise. You're not going to do any medical management. This is one way to see it. Second way, whenever you're seeing this question, no, see it like what is odd one out? The odd one out is there are three medicines, but one is some exercise. Why is it odd? In both these ways, D will become the best answer for this. Correct. So, according to my thought process, till now it is diaphragmatic exercise, but then with this minute question, it can be so much. You will give PPI, you will give prokinetics, and probably you will give TCA because it could be functional vomiting, right? You'll have to treat the depressive aspect of it. But then the clues that it's no retching, there is no nausea, they are able to bring it back within 30 minutes. They are not going to give you a direct opening that patient is getting it to mouth, trying to spit it or swallowing it. If they tell you that much, you know it is rumination. So from this question, I am thinking of rumination. Also, odd one out, diaphragmatic exercise. I would go for diaphragmatic exercise. So that's my answer. So I would go for diaphragmatic exercise as an answer, but still, it's debatable. It's how I think about it. One Rishabh has told rumination within 10 minutes. Nothing like that. Rumination within 30 minutes also is there. Okay, it may be up to date boss you have become, but then see through a lot of other things also. GERD, see, you still have retching here. It's not like they're going to vomit. How many patients come to you with vomiting in GERD? Tell me, until and unless there's a peptic stricture causing dysphagia and vomiting, right? So I really don't have diagnosis of GERD here whatsoever. Rumination is what I'm thinking, and if it's rumination, diaphragmatic exercise is something which is management of it. Okay. Again, debatable. Just to answer what I am thinking of. Maybe we can discuss more in our personal groups later. Okay. Then patient with bilirubin raised, talc phos raised, OTPT normal, recently started on ATT. Which probable drug between rifampicin and INH? I would say, yeah. So I would say in this question, INH and rifampicin are good enough to cause both, but rifampicin, if it is the cause, OTPT will be high. So INH is the preferable answer here because INH is something which will cause. So I have just mentioned brief difference between both. So INH, whatever it causes, no, there'll be normal AST, ALT, elevated bilirubin alk phos, whereas rifampicin usually will be associated with elevated AST and ALT. And unlike INH, there may be some history of skin rash and flu-like symptoms with rifampicin-induced liver energy. Okay, so good. The other two options were pyrazinamide and ethambutol. Pyrazinamide or pyridoxine. Few of you are also telling pyridoxine. Pyridoxine generally doesn't cause liver injury until unless given in really high doses. So maybe we'll just mention the answer as C, pyridoxine or pyrazinamide and D, ethambutol. Okay. Fine, we'll discuss about it later, but then I would say INH is the most best answer closest to this particular question. All are components of vocal pen score, which detects the preoperative mortality in a patient with cirrhosis. What is it? Creatinine, bilirubin, albumin, and ASA score. Fourth option was pyridoxine. So pyrazinamide and pyridoxine was there. But then, pyridoxine doesn't cause liver injury that commonly. So INH is the preferred answer. Let's discuss about it later. No ethambutol was there. Okay, fine. So no ethambutol was there, the previous question. So this question, vocal pen score is again a new score. It is it stands for Veterans Outcomes and Costs Associated with Liver Disease, slowly called vocal. And then it gives you a predicted post-operative mortality at 30 days, 90 days, and 180 days. The components are age, albumin, bilirubin, okay, platelet count, BMI, whether there's NAFLD, ASA score, is it emergency surgery or the type of surgery? And this is all the calculator that you use for this. So the answer for this will be creatinine, we didn't find them. Bilirubin, we did find. Albumin, we did find. ASA score, we did find. So answer for this question is creatinine. Again, this question can come next year if majority of you guys have got it wrong to decide the rank. So again, question for next session also. Okay. Each time when I'm telling this, please go through them for the next time also, or a similar score. They may come up with a similar one more score is there. There are some newer scores which we're using in MedCalc. They are available and we'll discuss it later. Once you know the topic, discuss about them. Okay. Next is again, simple question, chloride channel activator for chronic constipation. Lubiprostone is the answer. I've already mentioned it in QRP again. So this is the same table which I had mentioned. All these 5 mechanisms, know them and know their particular medications. You can row it the other way also. So lubiprostone is a chloride channel activator. Linaclotide is guanylyl cyclase agonist. Procalopride is 5-HT4 agonist. Inapronor is sodium hydrogen exchange 3 inhibitor. Okay. So know them the way it is. These are 4 drugs and 4 mechanism of action. So this can be question next time. Next. False among the following was asked. So false among the following was asked, and it's with respect to H. pylori regimen. And what are these? Culture is 100% specific but sensitive less than 80%. Probably it is true. It's a very specific test. Serology cannot differentiate between active and treated infection, obviously, because once serology is positive, it's probably going to be positive forever. Maybe its levels reduce. That's it. Serology is the only test unaffected by PPI. Only test itself is something telling me that probably if I didn't know anything about it, I would have marked this. D, PPI should be stopped 2 weeks before testing as it may lead to false positives. No. PPI should be stopped 2 weeks before testing as it may lead to false negatives. That will be the right answer. Okay. So I would go for D because what really happens is, suppose you have a stomach, you have H. pylori here. Once patient takes PPI, it's going to reduce this particular number. Okay, so it is going to make them completely normal. Okay, so when you are taking PPI, HP can become less because they tend to migrate more proximally and reduce, right? So you are probably going to get a negative result. So by stopping PPI, you're making sure whatever little H. pylori is there, they become more and you're going to get positive, correct? So what is the meaning of it? Stopping PPI 2 weeks later will help in reducing, okay, will get more positives. That means it is going to reduce the false negatives, right? This is a false negative. Correct. So PPI should be stopped 2 weeks before the test as it may lead to false negatives. This is the way I would see this. Okay. So I'm waiting for an options. Grossly, if I didn't know anything, sorry, excuse me for it. Serology, I would have gone for it. C, but then PPI, by reducing it, you are increasing the chances of you getting a positive test. Suppose PPI is there, you are going to get negative. It is a false negative. So you don't want false negative here. Okay. So the question will be, what is correct sentence? PPI should be stopped 2 weeks before the testing as it may lead to false negatives. Right? The option is D. I hope that the options are right and I've understood it the right way. Are you guys with me? Test will come negative, but it is false. So by stopping PPI, you're making sure that it doesn't happen. Okay. So I would have gone for D. Let's go for the next question. There's one question on mode of action of obesity drugs. True statement. I have no idea about the different options that are there, but what I can maximum tell you is make a table from Schlesinger. Okay. There are two things now, one you should add on. One is there are FDA approved existing drugs, like all this buprenorphine and naloxone and all this orlistat and older drugs, little newer drugs. And you have some newer drugs like STEP trial was done for semaglutide and few drugs like liraglutide, though they all can be added. And there are some novel drugs. So novel drugs are the ones where you have double agonist, glucagon agonist, triple agonist, and all that. So make this test of novel drugs and write their mode of action. Okay, because three questions so far in 3 or 4 questions have been asked on obesity on these drugs only. Okay, so make this table. They're going to be really useful for you guys. Okay, or we can all make it. Okay, so the question as from most of you, bupropion mode of action was asked. Okay, bupropion mode of action was asked. Now, bupropion. Topiramate was the other option, as per Dr. Krishna Sai. Bupropion mode of action was asked. Opioid antagonist and other options. So this question, I'm not sure about what is asked. If it is clearly bupropion mode of action, did they mention the mode of actions in the options? Okay, so probably bupropion was there in the question, and the options had different mode of actions. I'm assuming it's like that. Okay, so overall, you knew what to do and how to go about it the next time they ask you, right? That's what I want from you guys. So quickly make a table of recently approved drugs. Dupilumab mode of action. Somehow I feel I had discussed this someday, maybe in the WhatsApp group or in the question bank or QRP about dupilumab. Or, sorry, it was even discussed in the PG residency program where I had just discussed about newer drugs or the management of uh, eosinophilic esophagitis. How I remember to tell this to students is dupilumab, remember it as DIE, it has two mechanism of action. Okay. In this option, you would have directly gone for 4 had you known that. It was an IL-4 inhibitor and IL-13 inhibitor. It does both. But then if you go through the particular chapter on eosinophilic disorders of GI tract, at the end of the treatment in eosinophilic esophagitis, this is the line mentioned. There are studies which are evaluating a human anti-IL-13 antibody as well as a human antibody against IL-4 alpha chain, which is called dupilumab. Okay, so dupilumab has both these actions. If majority of guys have got it wrong, still don't worry. But few of the students who have attended very carefully the WhatsApp usual poll discussion, you guys would have got this right. Next is a question about EHPVO. Now, EHPVO, I would want to know the different options. I'm not sure what exactly is there. Most common cause of upper GI bleeding in children. Yes, it is the most common cause. It is true. Most common in developed countries. No, it is most common in undeveloped countries or developing countries. Isolated SME or splenic vein thrombosis may also constitute EHPVO. Yes, it can do. Etiology remains unknown in majority of the cases. It is true. So I would say it is true, true, true. Probably A is the best answer, considering that it is the odd one out in this particular question. Okay. According to Dr. Krishna Sai, the option was IL-4 receptor was there. So fantastic. That means we are going for it. So IL-4 receptor alpha chain and IL-13 antibody. Okay. So one is the antibodies. Okay. IL-13 antibody and IL force receptor alpha chain is what is blocked. So it's a dual action. Okay. So dupilumab, we got the answer right. Okay. Good. So EHPVO, again, we have the, not sure about the exact question. Probably it meant all are true about EHPVO, except as usual. And B sounds to me as the odd one out. One question on angiectasia, drug that can be used. We use thalidomide for angiectasia, first at low dose, followed by increasing dose, especially when there are multiple. The other drugs which sometimes we use are even drugs like OCPs and octreotide. But however, I'm not sure if the option was there. So I would stick to the options currently mentioned by students, and the answer is thalidomide. Next question is elevated bilirubin, ALP, HTLT, normal CT abdomen with contrast. There was no evidence of malignancy. What is the next step to be done? Next step to be done is to whether to see the bile duct and PD. I would do an MRCP abdomen. So I would do an MRI abdomen with MRCP. Okay. Suppose the question had a mass, suspected mass, then direct answer goes to USFNA. You are not going to do ERCP for diagnosis. Suppose patient has severe pain, jaundice, ultrasound showed dilated duct, then the chances of doing direct ERCP is much higher. Got it? So it depends upon how the question was asked. With this half-baked question, this is what I can tell you. I'm really sorry for this. Okay. So some of you have added it. Fourth option was natalizumab. Okay, we'll add on to the question. That is okay. D natalizumab. As of now, I am using thalidomide regularly for difficult injectasias and when they're diffuse and patient comes with recurrent anemia. Okay. Yeah. Let's go for the next question. LIRADS for HCC is based on which MRI sequence? Dynamic abbreviated MRI sequence, hepatobiliary imaging sequence with gadoxetic acid, non-dynamic abbreviated MRI sequencing, and all of the above. You students are really great. Okay. Dr. Badal Gondane, I want to just tell you one thing. When you do an MRI abdomen, one of the sequence of it is MRCP. So it naturally gets done. We can just discuss about it. So what we usually mention is MRI with MRCP, so that they are concentrating more on MRCP also. Okay, but then set of question. Sometimes see, you can just do EUS. If there's a stone, then go ahead with the ERCP also. Or if there is a mass, you can go ahead with biopsy. So I would be more happy if the question had a little more data to refine it and give you a better answer. But then MRCP abdomen, one of the sequence at the bottom that you're probably going to get if you ask the radiologist is also an MRCP with it. But coming to this question, which is again about MRI, LIRADS for HCC is based on which MRI sequence? Now, LIRADS, like BIRADS and THIRADS and everything, LIRADS for MRI sequence has so many sequence. It is dynamic, it is non-dynamic, it is one with contrast, it is one without contrast. So many things are there. Okay. I would say the best answer for this question is all of the above. Okay. Some of you might have mentioned, oh, two options are very different, dynamic and non-dynamic. Both of them cannot be in the same thing. And you might have mentioned either A or C or B based on what your thought process were. But then see, MRI as a word is single, but as a sequence involves many, many types. So you want to define, fine-tune things and tell a diagnosis. You see different aspects. Like when you send pictures of selfies now, you have different filters. The same way, MRI is not just MRI. You see the same thing with different filters or different sequencing, each giving different information. Okay, so simple picture is this one about recent LIRAD's recent version. I just opened it. So forget about the CT. That's not the question. With MRI extracellular contrast and then MRI with gadoxanate sodium. So many details and so many sequencing acquisitions, multiplanar acquisitions are there. So again, if you optionalize this, you can have DWI, you have subtraction imaging, you have multiplanar acquisitions. So a lot of types, and some of them even use hepatobiliary phase, transitional phase, different phases are also there. Some have T2 weighted, some have unenhanced, some have enhanced. So different things. So I would go for probably all of the above. Okay, that's what I would have done. If you have, okay, there's an explanation also. In LIRAD system, the assessment and categorization of liver disease includes HCC is based on combination of imaging features from various MRI sequences, including dynamic, contrast, hepatobiliary imaging, and non-dynamic sequences. Each sequence provides valuable information for diagnosis and characterization of liver lesions. Okay, yeah. Next question is, patient with suicide for paraquat. I think it's a general medicine question, but however, we get called maybe in first week or 15th day because the liver disease starts setting in for paraquat, and it's a very bad fatal disease. So from the option, what I can see and tell you, you give oxygen, you give steroids, gastric lavage acutely, but hemoperfusion probably is the answer. Probably the best person will be a physician who will be discussing the general medicine part of it. This point of time, because a question came in my list of gastro, I'm just mentioning it. Yeah, for paraquat poisoning, see, oxygen mask can be used, then this one and gastric lavage, but then hemoperfusion has not shown to consistently have any efficacy towards improving outcomes. Next is prevention of post. There's no more discussions. I would be happy if you guys keep telling it because there's a lag of at least 20 seconds between what I'm talking and what I'm getting here. So anyways, prevention of post-ERCP pancreatitis, all except question. See, this is also an expected question, no doubt. Rectal NSAID useful. IV NSAIDs plus or minus, we are not sure. To be frank, IV brufen in pediatric patients have been studied and have shown to be useful. But then, for general reasons, we don't mention IV NSAIDs. PD stent useful. Oral continuous infusion, again, useful for pancreatitis. Fluid in, useful for pancreatitis. But then, it's never mentioned specifically for post-ERCP pancreatitis. But however, I would say the best answer here would be IV NSAIDs. Okay. Upper GI bleed, patient on anticoagulation, has HB9, INR4, platelets of 70,000, drop in 25, postural BP is low. What should not be done? Option A, FFP, PRBC transfusion, C is vitamin K, and endoscopy in 12 hours. See, if you are fixated on endoscopy, that is the first thing you should never do in this patient. See, he's hemodynamically unstable. He has so many things to be taken care of. As a gastro and a hepatologist, you are going to get calls from ICU resident telling, sir, this is the patient, please come. But mind you, you are going to do more harm to the patient doing endoscopy at this point of time. Stabilize the patient, give blood transfusions, correct his coagulopathy, stabilize him, then we'll do the endoscopy. Okay. So what you should not think of doing is endoscopy in 12 hours. Stabilize the patient. In this scenario, this is what I will be thinking at this point of time. You have to do stabilization followed by other options. Okay. Then vitamin K antagonist was the option now. Oh, if that was the option, then you go for it. Vitamin K. This is a very tricky question. You're not going to give, sorry, warfarin for a patient who is on anticoagulation. It's as simple as that. So just decide between these two options. If it is vitamin K antagonist, that becomes the best option. If it was vitamin K and you have endoscopy at 12 hours, then I would say that D would be the best option at this point of time. Okay, it's up to you to decide how the question was. Okay, hemoglobin was 9. Okay, hemoglobin is 9. Why do you want to transfuse? So PRBCs can be the best. Patient not unstable, drop in HB. Okay, a lot of things. What to be done? Okay, and now I'll have to wait, see the chat box and see what exactly the thing is. See if it is see there were drop in HB, drop in systolic. That means patient is losing blood. His volume is less. HB is 9, can be hemoconcentration. It can still drop. He's already on anticoagulation. So my simple answer is stabilization, correction of coagulopathy, followed by endoscopy at 12 hours. If the option had vitamin K antagonist, obviously you're not going to give vitamin K antagonist here. Second, hemoglobin 9, whether to transfuse or not, I would wait, not immediately, but it's still in one of my options that I would keep option. That way, I would even keep endoscopy at 12 hours. I'm assuming that at by 12 hours or 24 hours, patient will be stable. That way, even that is the right option. So it's about how fine-tuned the question was asked. So let me see what options are there. Known case of AF, I'm not bothered about that. AF on warfarin presents with hematemesis mellitus, vital stable. What not to be done? So if that was the question, patient has AF, so he's already a cardiac patient on warfarin and has come with blood. Okay. You are very bad cases of bleed, vitamin K can be given. Otherwise, you go with FFP or PCC. But PRBCs at this immediate point of time, it may not be required. Okay, so the question is whether antagonist was there. Don't give it. That's definitely wrong answer. If C, it was vitamin K antagonist. If it is vitamin K, then the option will be PRBC transfusion is not required at this point of time, at least when hemoglobin is still 9 and patient is stable. You can always consider endoscopy in 12 hours. By then, you would have stabilized is the hoping point in this question. Okay. So what not to do? Vitamin K antagonist, you should not do if that is the option. If vitamin K is the option, then PRBC transfusion, you may wait. Okay, endoscopy at 12 hours is depending on whether the patient will be stable by then or not. If vitamin VKA was there, then obviously that's the answer. Okay. There's a guy, there's somebody with past history of CA uterus, and then hysterectomy was followed by brachytherapy, family history of metastatic ovarian carcinoma. Now she is presented with iron deficiency anemia. What is the next investigation? Is it a colonoscopy or upper GI scopy or a bone marrow biopsy or a PET scan? See, anybody with anemia comes first. I'm going to do an upper GI scopy. But with this patient having history of, hysterectomy, brachytherapy, ovarian carcinoma, you should always think in mind whether it could be HNPCC or, the syndromic conditions. If it is that, probably we will do colonoscopy also. So the question is, what first? I would probably do an upper GI scopy. But specifically in this question, what will be most useful to her next to rule out the cause of her upper GI of this? It may be colonoscopy. Okay. So it is totally depending on how you juggle this thing. See, in the same sitting, you can do upper GI scopy and followed by colonoscopy also. But why they have mentioned this history so much? Second, practically speaking, you have to do a colonoscopy for this patient, irrespective of whatever is their upper GI scopy. Upper GI scopy shows an ulcer, still you do a colonoscopy to rule out malignancy because of this past history. But the colonoscopy may be difficult to do because of the present adhesions. This is a practical problem because past history of operations, adhesions may be there. You might have a difficult procedure. But come what may, colonoscopy has to be done. Because what I'm thinking is about HNPCC. Considering this possibility, both are required is the dictum. Upper GI scopy is indicated, but then colonoscopy is crucial for surveillance in this patient. Okay. So let's go to the next option. Regarding esophageal esophagitis, false is different spectrum than GRD, less likely to respond to elemental diet and SFED, histological presence of more than 15 eosinophils per hypophil is diagnostic. It responds to local steroids and PPA. For me, I would say that all these three options are good. It is true. Eosinophilic esophagitis is nothing to do with GERD. Both are different problems. So GERD is one of the spectrum of eosinophilic esophagitis is also false. So I would go for A as the false statement because the rest of them all are true. But then this less likely to respond to this is also false. Because eosinophilic esophagitis is probably going to be responding to SFED and elemental diet. So it's between A and B. If you ask me which is more false, GERD is probably a spectrum of eosinophilic esophagitis, but both are slightly different. There's an entity called PPI responsive eosinophilic esophagitis. And I would say that eosinophilic esophagitis is something which is more likely to be responding to elemental diet and SFED, but it's difficult to follow. So the option I would mark is between A and B. Probably if you guys tell me more about the question, then I'll be able to decide whether what to be done here. Okay, there's nothing wrong, nothing right. But then majority of the options which are right are A, B, C, and D. But less likely to respond to elemental diet and SFED is not a characteristic feature of eosinophilic esophagitis. So B would be the better answer. Okay. Next question is long-term usage of PPI for GERD. Which of the following statement best describes its response? Now, improvement of heartburn, improvement in erosion, improvement in reflux symptoms, improvement in esophagitis. I think improvement in esophagitis is the best way. You have to have symptomatically there may be better, but then on scopy, if erosions and all the ulcers and everything is gone, esophagitis features are gone. Now that is the best option, because for most of the studies, long-term PPA use, the primary endpoint is described by endoscopic evaluation, and they say that reduction in esophagitis is often considered one of the primary targets, particularly in patients with erosive esophagitis or complications of Barrett's esophagitis. So esophagitis being reduced is the primary endpoint for long-term use. Okay, so that's the best options. Next is this question. I'm not really sure if you guys are trailing me, but then if you have any doubts, please post so that we can parallelly talk. I'm happy that even at 11:15, we have these many number of students hooked on to this particular program. 70-year-old man with GERD symptoms has hiatus hernia on PPI for long term. He presents with nocturnal cough for 6 months. Something was asked about his definitive management. A, double PPI, B, fundoplication, C, dietary modification, D is add prokinetics. If you ask me, patient has hiatus hernia, he is on long-term PPI. Probably next step will be double the PPI, right? And C. If it doesn't respond, then you do all the dietary modification, add a prokinetic. If it doesn't respond, considering the age, fundoplication may be a little too much at this point of time. So I would double the PPI at this point of time, okay? To reduce the nocturnal cough, probably add a ranitidine in the night. Yeah. So this is just a table to just tell you, see, patient with refractory GRD, how we treat. We have a lot of things. If there is increased TLSCR, I would give a baclofen. If there's hiatus hernia, based on age criteria, this and that, I would probably do a fundoplication. If the hypotensive LES, I would do few things. If there is reduced esophageal contractility, we would do few things like muscarinic agonist like pyridostigmine. If there is yeah, so if there is increased mucosal permeability, then we do few things. So based on the mechanism, we try to do few things here and there. In this patient, there is a hiatus hernia. If they have mentioned more about hiatus hernia, then you treat it directly. If they've just asked what is the best treatment, it is Nissan's fundoplication. But then if they tell you 75 not fit, what do you want to do? It's medical management. What is the next step I would do? I would double up PPI. So based on the question, definitive management will be fundoplication, not doubling PPI. Next step will be doubling PPI. Correct? So please, that's how you'll have to start answering the question. Got it? It's a very practical question. But if you tell 70-year-old with comorbidities, with so much this, that, it's not easy. It's going to take some time. Okay. So it's about it. Then increase in CT value of RT-PCR indicates low viral load, high viral. I'm not sure if it's a gastro question, but then we do deal with PCR tests. So what I can tell you is CT means that the number of cycles the test requires to reach the threshold to be detectable. If it was high, it means that the viral load was low. So answer is A. So it's like this. You have a virus, you have to cycle it to reach a threshold level to be detectable. If this particular phase is high, that means the load was very low. Okay, so that's how it is. So it's the same thing mentioned here. You guys can see it later. It's just mentioned clinically here. Next is the question was about AKI in cirrhosis, which is true. Unrestricted volume expansion is definitely false. Rise in creat more than 0.3 less than is true. Albumin infusion given for 48 hours is also true. Crystallized volume only when indicated is true. So I'm not even sure about the option. Probably it was all except. Okay. What you guys, however, have to know about is recently there is a definition. Old definition was HRS 1 and 2. Now you call it as HRS AKI and HRS NAKI. Here you have injury. Here you have disease. Okay. You have various definitions. Go through them. Again, useful. Then again, AKI in cirrhosis is not just HRS. HRS is just one component of it. But then many times etiology wise, you will have to attack at different places and your treatment might change a little here and there. From a practical perspective, I've put this slide. It is not for your question's sake. Okay, if you have this slide, you know, if I have an AKI in a patient with cirrhosis, first thing is you stop diuretics, you stop beta blockers, you stop ARBs, and then you do some urine test and do some basic tests. If creatinine is too high, do an ultrasound, see if there's renal calculi, this, that. And then you see if there's diarrhea, if there is raised bun, then probably it is pre-acceptable. And each step you start doing whatever management you have to do. If later, after doing all this, you realize it's actually HRS, then you start adding vasoconstrictors. This is the take-home message from this particular question. Yeah, some jokes. Good. Okay, guys. So now I have discussed most of the gastro questions. So next, I'm not going to discuss. I'm just going to scroll through. You guys just see it, and later PDF will be sent to you. Other consultants, Dr. Rajiv probably will be discussing about the general medicine questions. So I do not want to get into search domain. He will do a better job than me in this particular question. So I'm just scrolling through. Altitude sickness, not a risk factor. I'm tempted to answer, but I'm not going to. And then there is this question on Apache score. See, I could have grasped this question telling it is pancreatitis question, but then I felt, okay, fine, you keep it with general medicine. Next is this abdomen pain. Again, something towards gastro, but then I saw the options. I realized that it's something else, probably rheumatology related. Then there was this question on episodic generalized weakness. Again, please go through it later. I'll send you the PDF. So all discussed in our group. And then there was this question on amiodarone. Then this may match the following with respect to this skin lesions. Then there's a question on this non-anangap metabolic acidosis, what you're dealing with. Then there's reverse cardiology questions. Then there is this question on respiratory failure. I'll send the PPT. I'll send the PDF. Then there is one with respect to this particular sleep hygiene. I'm just curious to do this. Then about some respiratory failure. This question on antihypertensive of choice in pregnancy. This question on UTI, shock not improved, what about steroids, what to do, probably stress dose of steroids. UTI, AKI, hypokalemia again. So just discuss in the group, so I've just put it across. Later I'll be sharing with Rahul sir. Then atypical presentation of this particular renal question. Then again, secondary hypertensions. Then there is this question about mountain sickness, which came up. I think it was the first question also. Then there is this shunt in respiratory failure. I think we have repeated it 2-3 times. Maybe it's the same thing, but I didn't bother checking it. Aplastic anemia, again, there was some question. There was this question on some form of anemia and some hematological conditions. Then there is this neurological question. This is neurology questions. Please give tentative answers. Tentative answers to these questions, dude. Sorry, I've just jotted down the questions. Tentative answers to this. I'm the wrong person now because you will get it from other consultants in due course. Chat back to fantastic question again, an expected question. Then one of the students was very curious. He wanted to send this picture also to me on my WhatsApp separately. I was very happy, so I thought that if you guys feel this is the picture which came, please take a screenshot. I'll share it with other consultants when they're discussing the medicine questions. Please go through these questions. I feel probably there's an abscess and there's a narrowing on the other side. Some form of abscess, APPA could be. Then least likely to have features of secondary hypertension. It's a question again which is repeated, I think. Then there's this question on community acquired pneumonia. There's this question on body temperature regulation. Sorry, I have 5 options, but then, this is jotted down. You guys can discuss later. And statistics, though there was no statistics question this time, I was still tempted to put this question as statistics related. I'm not even sure what it is. But then, as per students, the option was the one which had adjust. So let's all adjust with the questions which we have got. Let's be flexible, take all the learning points from whatever we have got so far. I'm so happy that at still 11:30, we have so many students active. Thank you guys. Thanks a lot for being here. And if you have any doubts, we have an active WhatsApp group. Please put up there. We will discuss more and more. And for students who weren't able to attend the current session, it's in YouTube, so it's probably going to be there for a long time. You guys can look at it again and again in future also. So this was the picture sent in the group about PDSA. So P for plan, do for do, and S for study and adjust. So this was a picture sent by one of my student in the group. So thank you guys. I think now we shall disperse. Have a good night's sleep. Sweet dreams. Thank you.